Hi, Jess. I'm live. Hi, Bill. I feel like I'm saying I'm really thrilled to say things and do things to this group. And guess what? Here I am again, thrilled to present this next speaker to you. That it's just so lovely. Amy was an extern with Dr. Shin, and then came to the care center to be a predoctoral intern, and is now a postdoc with us. How lucky are we? Well, I'll let you judge for yourselves. No, really, we're very lucky. Here's Amy Weir. I know. Here's Amy Weir going to talk about development, autism spectrum disorder, and trauma, identification and treatment recommendations. Thank you, Amy.
All right. Thank you, Susan, for that lovely introduction. So as Dr. Timmer enumerated, I am a postdoctoral fellow currently over at the Care Center. I also have history working with autism as well down in Orange County, also up in Sacramento at the UC Davis Medical Center as well. So my presentation today actually comes from my experience in both the realm of trauma and also autism, and recognizing that in both realms, one being more focused in medical settings particularly as opposed to community mental health, that there wasn't a lot of communication between the two different areas of understanding for diagnosis, and so that was my purpose in creating this presentation. And so, just going. So our objectives for today is to understand the experience of trauma and how it complicates behavioral symptom presentations. Also to understand the overlap and distinct features of different disorders in children, so between trauma and autism spectrum disorder, or ASD for short. And then the available screeners for identifying possible trauma and ASD, and use of comprehensive strategies for screening, assessment, and diagnosis. And then best practices for trauma, ASD, and dual diagnosis. And so before I want to get started with talking about PTSD as a diagnosis first and foremost. So there are multiple criteria to hit for this particular diagnosis, and I won't be too detailed about this because I know that was our focus in this conference this year. So criterion A has to do with an identified stressor. So there's direct exposure, witnessing of, learning of others who've been harmed in an event, or indirect exposure to the details of a traumatic event. Criterion B would be intrusion symptoms. So these are unwanted thoughts or memories, nightmares, or flashbacks. Criterion C would be avoidance. So this would be avoidance of triggers of the of reminders of the traumatic event, so thoughts, feelings, and reminders. Criterion D would be negative alterations in cognition and mood. Criterion E, we're looking at alterations in arousal and reactivity. So this can be things like irritability, also problems with concentration, hyperarousal, and hypervigilance. And then the duration, we're looking at symptoms lasting longer than 1 month. Criterion G is the functional significance and the impact in daily functioning. And exclusion criteria, which would include symptoms related to medication, substance use, or other illnesses. And then specifying if with dissociative symptoms such as depersonalization or derealization, and also to specifying if it's with delayed expression, which would mean full criteria not being met until at least 6 months post-trauma. So there are multiple dimensions of trauma to talk about. So the child's symptoms of trauma are understood within the context of multiple factors, including the traumatic experience itself, the child's temperament and personality characteristics, also the caregiver's ability to help the child cope and provide a sense of protection and safety. And the traumatic events themselves can also include the loss of a primary attachment figure through death or separation. And then this will often overwhelm the child's capacity to cope and will elicit feelings of terror, powerlessness, and out-of-control physiological arousal. And then in preverbal children, it can be expressed through their bodies, and oftentimes is. So their capacity to regulate their bodily functions, relate to others, and explore their surroundings are impacted and disrupted. So the effects of traumatic exposure are numerous, and we've talked about that in depth throughout the last couple of days, so I won't go again into too much detail, but we have neurological and biological effects, which are related to brain development and understanding the biological and regulatory rhythms, and also somatic symptoms, so physiological symptoms that we can see. Self-regulation, which include challenges regulating affective expression, attention, action, and arousal, and also just challenges knowing and describing feelings and internal states. And then we also have challenges with attachment. So these are, again, challenges to basic trust and safety, as well as attachment disturbances and insecure patterns of attachment. There are developmental effects that we see. So sometimes we see regression in skills. So previously learned skills are lost. And then an exacerbation of normative developmental fears that may occur. And then also disruptions in developmental processes of stages and tasks. They may go a lot slower. And then social relatedness as well. So the avoidance or indiscriminate patterns of social interaction with others. And then we also see difficulties with pro-social skills as well. And then behavioral control is also another big one. So poor impulse control that we can see, self-destructive or injurious behavior, and also aggression. Then we also can see effects in cognition as well. So this has to do with difficulty focusing on or completing tasks, as well as planning for or anticipating future events. And then we also see sometimes learning difficulties or problems with language development as well. And so we talked about trauma, so now we'll talk about ASD as diagnosed through the DSM-5. So in order to establish a diagnosis of autism spectrum disorder, there are two separate categories that we look at. And the first one is social communication. We're looking at here deficits in social communication. And a child or an individual has to meet all three of these areas in order to be diagnosed with ASD. So the first one would be deficits in social emotional reciprocity. So that would have to do with abnormal social approach and problems with to and fro conversations. Also deficits in nonverbal communicative behaviors used for social interaction. So this has to do with body language, so nonverbal gestures, things like shrugging, pointing, and also eye contact, and the integration with verbal skills as well. And then also deficits in developing and maintaining developmentally appropriate relationships. So that has to do not only with problems with imaginative play and sharing with peers or other individuals, are also seeming to maybe not be as interested in other children, but also can go to problems with adjusting their behavior to different social contexts as well. So the second area that we look at for ASD would be the restricted and repetitive behaviors or interests. So there are 4 separate subgroups or sub-areas here that we look at, and in order to be diagnosed with ASD, you need to meet all 3 in the social communication deficits and have the presence of at least 2 of these restrictive repetitive behaviors. So the first one would be stereotyped or repetitive motor movements or use of objects or speech. So motor stereotypies, echolalia, flipping or lining up of toys, and also idiosyncratic speech that just sounds unusual, that is unique to them. And then an insistence on sameness, inflexible adherence to routines or ritualized patterns of behavior. And so this can be difficulty with transitions, problems with small changes in routine, and also very rigid thinking patterns. Then we also see highly restricted, fixated interests that are abnormal in intensity or focus. So that can be as strong attachments or attachments to or preoccupations with things that are unusual. So I've seen kiddos that are interested in just opening and closing doors. And so that's unusual for any age, quite frankly. Or numbers or signs, things that are just unusual for a kid to be into. And also things that are typical for a kiddo that just may be the only interest that they will share with you. So a 5-year-old who's interested in dinosaurs, and all they will talk about with you is dinosaurs. And then also talking about hyper or hyporeactivity to sensory input or unusual interest in sensory aspects of the environment. So this can be an indifference to pain or temperature, and also just having adversive responses to sounds or textures or visual stimuli as well. So thinking about autism spectrum disorder, it can be diagnosed reliably in children as young as 2 years of age. And it's through experienced clinicians or researchers that use standardized instruments to provide a very comprehensive evaluation to provide these diagnoses. There are 4 times as many boys as girls that are diagnosed currently. Our rate per CDC is 1 in every 68 children is currently being diagnosed. And then we don't know the underlying cause. And there is no single behavior that means a child has autism. In fact, it is a spectrum disorder that's made up of a constellation of behavioral symptoms. And so a growing number of children with autism are described to also to have gone through a regression in skills and losing previously acquired skills. And this is something new that we are finding as well. So where are we now? What do we know? We know that ASD is increasing. ASD is also caused by an abnormality in the development of the brain, and that it's a genetic disorder that can also be associated with other genetic disorders, such as Fragile X syndrome, 22q11.2 deletion syndrome, and also tuberous sclerosis, among many others. And that early intervention improves long-term outcomes overall, and that symptoms are present as early as 12 months. And then what do we not know currently? We don't know why ASD is increasing, and we don't know what causes the brain abnormality or how to avoid or fix it. We don't know which genes cause ASD, and we don't know what specific interventions that will be best for each individual child. We don't know the best methods for early identification currently. We're at, again, 2 years, and that's pretty good to be reliably diagnosing, but we're trying to identify it as soon as possible. And then the epigenetics that was talked about yesterday. We don't know how the environment is playing into those predetermined genetic factors and impacting behavioral symptoms for our kiddos either. So when we're diagnosing or assessing a kiddo, we look through different lenses. So when someone is diagnosing for or looking for an autism spectrum disorder, they're looking through a developmental lens oftentimes. What are they looking for? Developmental functioning, history, caregiver report, medical considerations, environmental factors, social skills, communication, play, behavior, and collateral information. Now, when you're looking through a trauma lens for a kid with trauma exposure, we look at the history, emotional and behavioral reactions. We also look at the relationships with current caregivers, the ability to regulate emotional and bodily states, social skills, play, and presentation in different contexts as well. And so, as you can hear, some of those overlap. And so it's thinking about what's the lens that I'm looking at this child through. So there are many overlapping symptoms across ASD and trauma. And so just to name a few of them, we can see lack of social initiation, poor eye contact, delays in language, we see aggression, self-injurious behaviors, tantrums, sensory sensitivities, among many others. So it's helpful to understand where these overlapping symptoms come from in these different disorders in different areas. So for trauma, we can see a withdrawal or lack of eye contact with no social initiation or no interest in social interaction. Where does that come from? It's due to mistrust of others. And so with ASD, we do see a lack of eye contact, no initiation of conversation, no pleasure shown in social interactions. Where does that come from? Deficits in social emotional reciprocity. So in trauma, we also see issues with trust, fearful of adults, and avoidant of adults oftentimes. Where does this come from? Due to past traumatic experience where their trust of others was violated. In ASD, we see no response to name at times, and a reduced sharing of interest with others. And this is going to be a repeated theme. Where is it coming from? Lack of social emotional reciprocity and difficulty sharing their interests. So for trauma, we also see depression, anxiety, and difficulty with identifying, expressing, and managing their emotions. It comes from a problem or internalization of the traumatic experience itself. In ASD, we also see a reduced sharing of these emotions and affect, and also that social initiation piece is low. And this is, again, due to inherent deficits or difficulties with social emotional reciprocity. In trauma, we see the impact of traumatic experiences on empathy, social relatedness, and trust and turn-taking. So this comes from the violation of trust in relationships. In ASD, there's difficulties with relationships and taking another's perspective. That again comes from deficits in theory of mind skills. So that talks about agency and understanding that others have different agendas and taking the perspective of other people. So that is inherently related to deficits in social emotional reciprocity. In trauma, we see tantrums, unpredictable emotional responses, anger, and overreactivity. So this comes to emotional dysregulation. In ASD, we see tantrums, headbanging, self-injurious behaviors, and there are multiple aspects to this. So this is due to deficits in communication skills, problems with changes in routines, and also sensory-seeking behaviors are thought to contribute to the self-injurious behaviors in ASD. And to look at some more overlapping symptoms, we see nightmares, fears of going to sleep, and trauma. This comes from revisiting memories of trauma and those symptoms of intrusion. For ASD, we also see sleep problems, but they are differently associated because they're due to inherent problems with their sleep cycle. So night waking, problems falling asleep, problems with early morning waking. Oftentimes when I would see kiddos on the spectrum, I hear that they're only sleeping a few hours a night. They don't have consistent sleep cycles, and there are thoughts that there might be neurological pieces going into that as well. So there are changes in appetite in trauma, and this is due to mood dysregulation. In ASD, we see eating problems, so with rituals and pickiness, and this is related to sensory interest and problems with the changes in routines. So one of those, what we call them RRBs, so the restricted and repetitive behaviors and interests. In trauma, we see hypersensitivity to sounds, smells, touch, sensory input in their environment, and then being unaware of pain or internal physical sensations. And this is due to hyperarousal or reminders of the trauma, and also hypoarousal in the instance of low pain awareness. And so in ASD, we see an under or overreactivity to sensory input as well, but this is due to an inherent diagnostic criteria of having sensory sensitivities in general. We also see in trauma dissociation, and this is used as a maladaptive coping mechanism that developed post-trauma. In ASD, we often hear caregivers or others describing kids as living in their own world. But this is due to that inherent difficulty with social emotional reciprocity and limited interest in seeking out other peers. So deficits in language development and abstract reasoning in trauma, and this is also due to early trauma and brain development and potential regression in skills. In ASD, we see difficulties with pragmatic or social use of language. And this is due to problems with, again, social emotional reciprocity and commonly co-occurring language delays. Many times you will see a kiddo that has a co-occurring language delay that is on the spectrum as well. And then in trauma, we see difficulties with changes and transitions, rigid repetitive behaviors, repeated play themes, and fixated interests. This is related to the anxious reaction to control the unpredictable nature of trauma itself. In ASD, we see an insistence on following routines, lining up toys or objects, repetitive behaviors, and fixated interests. What is this related to? So this is that restricted and repetitive behaviors. That is one of the core symptoms of ASD. So what are the distinct symptoms between the two? So in ASD, symptoms must be present in early childhood, so before the age of 3. Social concerns may not be evident until the demands placed on them, the social demands that are placed on them, are much more increased. And then the consistency of symptoms across settings and also across the lifespan as well. However, they do change, but it also is those symptoms may change in a manner that still reflects those deficits or the presence of those restricted and repetitive behaviors. Scripted speech, so this can sound like a kid literally reading a script where there's no intonation changes, and so it literally sounds like a kid's reading a script from a movie. Fascination with movement or parts of objects, so we call this visual inspection a lot of the time, where a kid may be interested in the wheels of a car and watching it spin rather than actually playing with the car as a whole. And then also stereotypical movements and movements of their body. In trauma, a distinct symptom is exposure to a trauma that has to be present too. Re-experiencing through flashbacks, as an example, and then hyperarousal, also hypoarousal, then acting in or acting out behaviors, so aggression being an example of that, and then disorganized attachment styles, so approach withdrawal, and then increasingly restricted range with displays of affect post-trauma experience. So the affective response becomes much more restricted after the trauma has occurred, rather than being consistent across the lifespan. And then sensory-based trauma associations that are, again, uniquely linked to the trauma experience itself. And then also the exacerbation of typical developmental fears. So there may be an exacerbation of fear of the dark as a result of a traumatic experience that may have happened, for example. So thinking about assessment and treatment, it's important to talk about the perceptions of the caregivers. So we have to think about the caregiver's own history of trauma and also of development too. Because we do know that ASD is a genetic disorder. And so we see lots of links through extended family members and primary caregivers as well. There can be a misattribution of symptoms to one or the other, oftentimes as well. And then a lack of understanding of typical development can occur for caregivers as well. A biological parent also may not want to admit that they caused harm to their child as well. So thinking about that as a protective factor for them. And social skills deficits in the parents or other siblings may occur, thinking, well, he's just like me, what's wrong with that? So again, that genetic inherited piece of developmental concerns. And then the view that autism diagnoses may create secondary gains and get the child services. And then also an underestimation of the impact of trauma in infancy, in that they do experience trauma as opposed to what is commonly thought by many people too. And so we also have different screeners to identify ASD. For trauma, we have brief measures that we use in a manner that's similar to screeners. So we have the trauma symptom checklist for young children and the trauma symptom checklist for children. So one is for the self-report and the other is for the parent to fill out or the caregiver. Then we also have the UCLA PTSD Reaction Index for DSM-5. For ASD, we use the Ages and Stages questionnaire. This is actually to look at development overall. And then the modified checklist for autism in toddlers, the revised with the follow-up interview, and I will talk about these a little bit more in detail. And the social communication questionnaire will look at symptoms of ASD in preschool and school-age children. So the trauma symptom checklist for children is, again, a brief measure that it's a 54-item self-report scale for trauma symptoms related to sexual abuse, but also looking at trauma symptoms overall. And it has 6 clinical scales associated with it, with the TSC-YC, which is given to the caregiver to also similarly look at the symptoms of trauma. Now, the TSCC is developed for 8 to 16 years, and the TSC-YC is developed for 3 to 12. The UCLA PTSD Reaction Index is a semi-structured interview that assesses for trauma history and a full range of PTSD symptoms. This is developed for 3 different areas. So we have the child, which is a school-age child. We have adolescent form, and then we also have a parent or caregiver form. And this is also available in Spanish and German, which is pretty cool. So, and then we have the Ages and Stages questionnaire. So this is a 30-question survey of developmental progress with 10 open-ended questions related to concerns of the caregiver. So it was developed for parents to fill out, but I think the best information often comes from the clinician themselves and being able to do some of the tasks with them. And then there's also the associated ASQ social emotional questionnaire, which will also give additional information provided from the caregiver about social emotional development. And this is also available in Spanish too. And then we have the modified checklist for autism in toddlers. And so this one is distinctly looking at autism symptoms in kiddos that are 16 to 30 months of age. The American Academy of Pediatrics guidelines stipulates that autism screening should occur at 18 and 24 months of age. And so if there are kiddos that are in your practice that are of this age range, it's not a bad idea to provide this screener. So it's a 20-question survey that looks at, again, different symptoms of autism, and then there is a follow-up interview to reduce false positives. So if there are any items endorsed, there are follow-up interview questions that you can ask to get more detail about these particular symptoms. The social communication questionnaire was a measure developed to assess communication skills and social functioning in children who may potentially have ASD. So the minimum age for this questionnaire is 4 years with a developmental age of 2 years. And so this is used, cutoff scores are used for this to provide understanding whether there needs to be more assessment done or a formal evaluation should be considered for this kiddo. So our assessment components for ASD include direct observation and interaction with the child, our autism evaluation proper, which usually includes an ADOS or an ADI, developmental or intellectual evaluation depending on the age of the child, a language assessment, and looking at their adaptive skills. For a trauma assessment, we're looking at the trauma exposure, the triggers, family functioning, and considerations for safety, integration, and information, and ongoing assessment. Now, what overlaps for both forms of assessment is looking at the early developmental history, their current concerns and symptoms, their resilience factors and strengths, and also just multidisciplinary involvement in the process. So next steps for having developmental concerns is to refer the child out for a complete medical exam, including an audiology exam, particularly with language delays, and then getting a genetics microarray as a recommendation as well. And then we also recommend neurological exams when there's a presence of either staring spells or seizures. And then a California Early Start referral would be made for kiddos under age 3. And I'll talk about where they can be provided. And so we also talk about speech and language evaluations for, again, delays with speech and language. Occupational therapy evaluation if there are identified sensory sensitivities or fine motor concerns. And then also physical therapy too if there are gross motor concerns. And then interventions to address the behaviors and social emotional functioning. So where do you obtain these services? So early intervention programs can be provided through the regional center for under age 3, but also school districts can provide these as well through an individualized family service plan, or for over 3, an individualized education plan. And then also insurance providers can give these. So treatment considerations for trauma include trauma-focused cognitive behavioral therapy, PCIT, and PCAT. And then there have been use of trauma assessment pathway and child-parent psychotherapy. Now for ASD, there are different areas to consider with treatment. And so I have links here that unfortunately we don't have time to go through. But we would consider speech, occupational therapy, and physical therapy to address those needs. We would also look at applied behavioral analysis, including discrete trial training and pivotal response training to work with behaviors in the moment and create a structured learning setting for them. And then we would also consider, so a potential is Early Start Denver model, which has a lot of similarities to CDI in PCIT. It really allows for the child to lead and the parent to follow and use those moments to have teachable moments for the kiddo. And we also have the TEACH model, which it's a structured teaching model that uses visual and physical strategies to target communication, organization, generalization, and concepts with sensory processing and social relationships. Then the floor time has also been used too, and this focuses on the emotional development by training parents to enter a child's world and respond appropriately. And then cognitive behavioral therapy has also been used. However, this is used for kiddos with co-occurring mood issues or anxiety concerns, but these kiddos also need to have complex language and able to have some abstract thought. So treating children with a dual diagnosis. So limited research currently exists on this, and there's also misconceptions about this population. And so a lot of people think that they don't experience or understand trauma, or they're not capable of being involved with the treatment. However, we know that hallmarks of trauma treatment include acknowledgement of the trauma, safety and competency, and making meaning or understanding of what happened and how it affected the individual and how it's different now. So treating children with a dual diagnosis, so PTSD is often missed, and TFCBT is usually considered choice treatment. We know that PCIT also works separately with trauma and also emerging evidence for ASD too. It's just limited research on co-occurring disorders. And then interdisciplinary collaboration is critical, and that co-treatment is also thought of too. So use of simple language, visuals, concrete metaphors, building those coping skills, and personalizing the traumatic experience. So conclusions would be to gather information across settings and include regular interdisciplinary consultation with others in the child's network. In evaluating the child's response to the intervention consistently, as well as consulting and co-treating when possible, and diagnosing carefully and evaluating over time. Could the symptoms be related to trauma, ASD, or both? And then dialoguing around the priorities and sequencing of services. So the major takeaway points that I want you to leave with are that behavioral symptoms are complicated when a child has experienced trauma. And there's a lot of overlap between the symptoms of different disorders in children, and that children change over time. And a careful and comprehensive approach to diagnosis and interventions, especially important when a child presents with a traumatic history and also with potential concerns about autism. And so I have some resources here that can provide to you individually. We don't really have time for questions, but I'd be happy to provide them to you after. All right, thank you.
Thank you so much, Amy. That was wonderful. And now we have our team in the back that is about to lead us in our 5 minutes of movement.
So as you see, the ladies up here are in the front of the room with some beach balls. And when the music starts, the object of our active play activity is to keep these beach balls in the air. And we have 3 consecutive songs that we are playing, and we just want you to have fun with the songs, enjoy them, and you can sing along. And thank you very much for playing, as our beach balls say. And so without further ado, we are going, please stand if you're able to, and stretch and keep the beach balls in the air. Feel free to dance along, sing along, scream along, jump along, anything you like. If it's your favorite song, raise the roof and keep the balls up in the air. All right? Are we ready? Another song coming up, keep the balls in the air. Could not end the summer without playing our favorite song. This is for Dr. Timmer.
Okay, everybody stop. Red light. Orient. And now, is this our last presentation? And then Anthony, yes. I would like to welcome to the podium Dr. Brandy Hawk and Lindsay Forte, and they are going to talk about PC Care. Oh, I love talking about PC Care. Fostering secure placements for traumatized children in transition. Thank you.
Hello, and thank you for hanging out to listen to us. I am Brandy, and this is Lindsay. We are going to talk to you about PC Care, which is an intervention that we've created, which is a brief 7-week, 6-treatment session intervention for kiddos that relies heavily on the theories underlying PCIT, but which specifically targets what we heard over and over and over again yesterday, which is that PCIT has really high attrition rates. And it's very difficult to keep kiddos engaged. And so PC Care is short and sweet and gets them everything in a very short period of time. So last year we presented on PC Care in general, and this year we'd like to present very specifically on a grant that we have, a project that we have going to provide PC Care services to children in foster care. Okay, cool. So we're going to start by talking about the state of foster care in Sacramento County, which is very specific to us, but is probably applicable in LA as well. And then talk about the goals of this specific project, and then hear a little bit about the PC Care protocol and some research thus far. Oh, go back. Okay, sorry. So in Sacramento County, children are entering foster care at a higher rate than children statewide. So we can see California in general has about a rate of 5 per 1,000 children aged 1 to 2 years old entering foster care, which PS is not good to start with. But also then an additional 4 out of 1,000 children who are 3 to 5 years old entering foster care. In Sacramento, those numbers are much higher. So we have more like 7 per 1,000 children aged 1 to 2 years entering foster care, and more like 6 out of 1,000 children aged 3 to 5 years entering foster care. Now what we know, one of the things we know about foster care is that placement stability is incredibly important for children's mental health. So first of all, by necessity, all of these children have lost one placement, their biological family. And when they move into a new placement, they have to learn all sorts of new things. They've experienced something that got them removed from their parents' care, and they're at higher risk of mental health once they enter foster care. What we know is that children with disruptive behaviors and children who have more externalizing behaviors are at a higher risk of placement disruption, of having to leave another home and go to another home and learn new rules. And what research also shows is that once children have made one placement change, they're more likely to make another placement change. And in California, it's a problem. So in California total, there's about 55% of children are in 2 or more foster placements. In Sacramento, it's a really big problem. So in Sacramento, actually 65% of children are in at least 2 placements, post-biological caregivers. So we thought this is a problem and we need to stabilize these placements. So we are going to provide a trauma screener to every single newly placed foster child aged 1 to 5 years in Sacramento County as they enter a new home within the first 90 days. We're going to provide PC Care to those families that let us and give them in 7 weeks something to help stabilize this placement and reduce externalizing behaviors. We are hoping to increase that stability in placements, to reduce trauma-related symptoms in children, and to act as a service provider who can refer to additional services, because we know that a 7-week intervention is not going to cure all children who are in the foster care system, but we want to be a start. So these are our goals. They're really, really lofty. In our first year, we were hoping to see 250 children and about 500 children per year after that. Sadly, this is based on data that's about how many children aged 1 to 5 years old enter the foster care system every single year. And we've been working with CPS in order to make this happen. We can't do it on our own. We need to be part of the system. And so this is a little graph to show where we come into play. So children are placed in new foster homes, and pretty much right away, CPSU, which is the central processing system of CPS, will put a referral in for PC care for every single child aged 1 to 5. And then there's a clerical person at CPS who will track that and send us the referral. Within 1 to 3 days of receiving that referral, we call the caregiver in order to see if they're interested in services, and then we send that referral onto a therapist to start services. So we're trying to get in there super, super fast. As part of ongoing efforts to maintain a continuum of care for these children, we're providing updates periodically to the Children's Law Center, which are the child advocates, to CPS, and our goal is to make secure placements for these children. So,
All right. So what is involved in PC care? What does it look like? And those of you who joined us last year at our workshop will have seen it in a little bit more detail. But I want to talk about sort of what's involved in PC care with regard to this project specifically. Okay. So first and foremost, because our goals are twofold, reducing trauma symptoms and stabilizing placements, the first thing that we want to do is get in there and engage the family and also screen for trauma symptoms. So within the first 1 to 2 months of placement, so we're trying to catch these kids in the first 60 to 90 days of their new resource home. We're going to get in, and sorry, I thought that was part of our presentation. We added some audio just to make it more emotional. But first we'll get in there, screen for trauma symptoms by using this ECTSS, the Early Childhood Trauma Symptom Screener for 0 to 6-year-olds, which works out perfectly because, of course, we're trying to see kids that are ages 1 to 5. And we're going to engage with the foster family by sort of talking to them about what they can expect in the next 6 weeks. We're also going to assess for disruptive behaviors because we expect to see quite a bit of those. Of course, we might have families, and we have had families say, oh, well, this kid's been with us for about a week, no behavior problems, no big deal. But then it's sort of important to remind them that those behavior problems might not be showing themselves right now, that this is a really big transition for these kiddos. So we're going to provide some psychoeducation about what trauma looks like in kids within this age range, and what behaviors might be attributed to some of the trauma that they've experienced. So we've put together some really nice age range specific trauma handouts. So we've got information about kids 0 to 2, right? Or 0 to 1. And then we've got for older kids, just how trauma sort of manifests itself behaviorally for those different kids. So this is the outline of our PC Care course of treatment. So we've got that intake or assessment session where we go in and sort of orient the family, provide some psychoeducation, and we also provide a 12-minute observation to sort of see what skills are already being used, what behaviors are already being displayed, and we provide some standardized measures for our research. And then each session after that, we're going to be teaching some new skills and then practicing them via coaching. So any given session of treatment will look like the therapist coming into the home, providing maybe up to 7 minutes of a check-in, which includes, did you practice at home this week? And 7 minutes is key because we've only got 6 weeks to get a lot done, so every minute counts. We've mapped it out to the minute. So we've got 7 minutes for check-in, and then they do a 10-minute didactic. So you'll see session 1 includes the pride skills, transitions, compliance-friendly environment. That's all done in 10 minutes, which is sort of a mind blower. But we've got really, once you get in the swing of it, I think it can be done really effectively. Then we do a 4-minute coding session. And then the bulk of the session, 15 to 20 minutes, is dedicated to live coaching. So you're teaching the skills within 10 minutes, but then you're really getting the parent to let those skills sink in and see how they work live in the moment right away. So lighter on the didactic side, heavier on the coaching side. Anything else you want to say about the course of treatment?
No, just that it is, this is what we do in every session. So there's no going back and redoing session 1 again. We go through and cover these things in each session as we go along.
Perfect. So for this project, generally PC Care, and you'll remember from our workshop, is for kids ages 1 to 10. For this project and this grant that we were awarded, it's for children ages 1 to 5 years old. Which obviously, as Brandy talked about, is a really crucial age range to hit in the foster population in Sacramento County. So we're trying to reach these families and these kids within the first 60 to 90 days to stabilize those placements. These can be any sort of resource home. It can be kin caregivers, it can be RFAs, really any caregiver that's taken this child in. And we're doing assessment, and obviously it's a preventive intervention since we're getting in there so quickly, and we might be catching them before any disruptive behaviors are really starting to be disruptive. And yeah, assessing for those trauma symptoms is key as well. Anything else about that one? No, I don't think so. Thank you.
So this is where it gets really fun for nerds who like numbers. Okay, so does PC Care work? We love PCIT. PCIT is wonderful, and we should continue to do PCIT. What we know is that PCIT has a very, very high attrition rate. And so can we work with these families in a short period of time and see positive outcomes? I'm going to caveat this by saying, in a few slides, we're going to talk about some barriers that we've had to getting this project off the ground. And part of those barriers are that based on the project, we haven't been able to see a lot of clients quite yet on the project. So this is all of our PC Care data combined. So this is 40 caregiver child dyads, not necessarily foster children. Some are foster children, some adoptive, some biological. The range is 1.3 years to 10.9 years of age. And so first of all, pretty graph. These are ECB scores. So our ECB intensity scale at pre-treatment versus the ECB intensity scale at post-treatment. So there is 7 weeks in between these two scores. They're going from clinically significant to non-significant. The ECB problem scales, which is the is this a problem for you scale, is going from clinically significant to non-significant in 7 weeks. And I'm very much like this part. 74% of our kiddos had clinical levels of behavior problems at pre-treatment. Only 32% had clinical levels at post-treatment. And really, really important, we have a 93% retention rate. Yeah. So people are able to do it and graduate and see change. How much change, do you ask? Well, it's a lot. So approximately 40% of our sample was more than 1 standard deviation better on the ECB at post-treatment. An additional approximately 20% were at least a half standard deviation better on the ECB at post-treatment. And then there's about 20% in there that were only slightly better by only 8 to 17 points. And then about 20% of our sample either had no change or a slightly worse ECB, which is only about 6 to 7 points worse. So they're improving a lot. And weekly, we give the WACB. And so you're all used to the WACB N. This is the PDI WACB, not the CDI one. So better is lower. And you can see week by week, our WACBs are getting better. So they are consistently improving every week of treatment. And this is the change scale on the WACB. That's the column, do you think this behavior needs to change? Yes or no? And this too is consistently going lower and lower each week. Our parent skill use. So one thing that we didn't talk about this year so much as we did last year is PC Care is quite different than PCIT. It is not abbreviated PCIT. It is its own thing that shares very similar underlying philosophies. One thing that's very different is we do not care about parent mastery in PC Care. We do not differentiate between the types of pride skills. We include unlabeled praises as pride skills and reflective questions as pride skills, and we lump them all together as pride skills. We also include imitation statements. I'm driving a car just like you is a pride skill, and I love spending time with you is a pride skill. So that's what this blue line represents. It's the entirety of their pride skill use. And again, we're not pushing for mastery, we're just pushing for doing it more. So you can see from an average of about 7.5 pride skills for parents at pre-treatment up to about 17 pride skills in 4-minute observation at post-treatment. And then the avoids, again, we tell parents to avoid, but there's no mastery, and we mostly don't care except really for the negative talk. We don't want them to criticize their kiddos. So we want to see that decrease, and you can see it's going from 17.8 in 4 minutes to about 12.4 in 4 minutes. So the parents have shifted pride versus avoid. And then something that we really want to see is a reduction in trauma symptoms. We're talking about trauma with the caregivers, we're giving psychoed in the beginning, we're using trauma in our coaching and in our teaching, and what we see in a smaller sample of the TSCYC is that their PTSD total scores went from highly significant, 72.2, to non-significant at 59.9. So in just these 7 weeks, we see a really nice reduction in trauma symptoms for the kiddos as well.
All right. So some of the barriers so far to this project, and that you can think about if you're ever sort of trying to implement a new project within a larger system. So we were working with CPS, our Child Protective Services in Sacramento County, which is a very large, very established, very well-oiled machine, but it's running, it's been running forever. And we were trying to figure out, where can we fit in? Where can we be of help and not sort of get tangled up and trip up this system that's already in place? So that had been a challenge. Luckily, we really found that our colleagues there are great, and we were able to sort of find our similar goals and focus on those. And also, I think something that was key was sort of finding, I know we've talked a lot about language over the course of these conferences and presentations, finding sort of a similar language that we're speaking to get them on board. We've also found that some of these families will refuse services. As part of our research, we're not mandating this service. It's an option for them that we hope will be really helpful. But because it's not mandatory, some parents or caregivers will refuse, and some feel that it will be a lot to add to their already very full plates. And also, so the last major barrier that we found is training social workers in the area and training or informing resource caregivers about what PC Care is, how it can help, who it is for, who should be referred, who we are, and when they should reach out to us, that kind of a thing. So really making sure that everyone that's involved in this community knows that we're here to help and how to reach us. So far, the project is getting off the ground, but we've completed treatment with 3 clients in the home, all with good outcomes. And there are currently 14 clients in treatment that are just about to finish after this conference. So we're very excited about the outcomes that we're seeing so far, and we look forward to giving you more data as this project gets even further off the ground. Okay, so I think that wraps up the information that we wanted to give you so far, and we might have 2 minutes for questions.
Yeah.
If the therapist is out for a week, how do you guys adjust the model, or does a different therapist step in for that week?
It's okay to miss a week. So it's 7 weeks of treatment, but kids get sick, therapists get sick, they go on vacation, and it hasn't affected outcomes to have 1 or 2 weeks missed in treatment.
You just look back. That's it. Okay.
Yeah.
At this time, does the model, is the data that we're simply representative of families that are not autistic speaking, or so far is it only targeting families into English? And if so, does the project have plans to expand to Spanish speaking clinicians and private services?
That is a wonderful question. Thank you for asking it. She asked whether the protocol is available in Spanish and whether it's being used in Spanish. And for that answer, I need to give a huge, wonderful shout out to Elizabeth Mota Garcia back in the back. Look at her. Who has translated the entire manual into Spanish and has been using it with Spanish-speaking families, both for this project and in the clinic with non-foster families. So yes, absolutely.
And at this time, you guys offer training for any services that want to practice that we have any knowledge, or any idea that this exists, or that they should use it?
I'm going to let Lindsay answer that question.
We have developed a training model, and we are also in the process of getting that off the ground. We've trained a couple of agencies as individual agencies so far, and we look forward to training more agencies as well, and possibly in other formats as well. I think, Susan.
Do you want to just speak to the PCIT background versus no background in PCIT?
Do you want me to do that? Yes, please.
So I also want to talk a little about training. So this is a PCIT conference. Y'all do PCIT. That's beautiful, sets you up wonderfully for coaching in PC Care if you want to be trained. You do not have to be trained in PCIT in order to be trained in PC Care. They are very different treatments, and so people who are PCIT trained tend to find some parts very wonderful and some parts a little bit more difficult. People who are not PCIT trained tend to find the opposite things difficult versus wonderful. And we've also trained licensed and unlicensed staff, psychologists, master's level trainees, and bachelor's level support individuals who go out in the home to support behaviorally with our families. Bill?
I was just wondering, your PCIT program has served a lot of foster kids in the past. How are you dealing with that now with PC Care?
I see you walking away from the podium. Interesting. That's a great question he asked. We have a very strong PCIT program that served many foster families, and that's not changing. We continue to serve many foster families with PCIT. PC Care is being used as that initial preventive intervention stabilizer. And so it's possible that after going through PC Care, these families will not need PCIT anymore, which could reduce referrals for that. But someone could be in a foster home for a long period of time, and the caregiver at that point says, I need treatment. And then they could come in and get PCIT. Additionally, we're figuring out exactly what to do once a child has completed PC Care. If they continue to have very disruptive or aggressive behaviors, we have a number of ideas, but referring on to PCIT is one of them. So it's not a necessity that if you've done PC Care, you can't do PCIT. We're just trying to figure out the best way to make that transition happen. Oh, yes. Any longer, what do you mean? Oh, no, the sessions are timed to the minute, 52 minutes long, which gives therapists a lovely 8-minute leeway, just in case. But no, our initial intake session for one child is scheduled for an hour and a half. We've had a number of siblings, which is another barrier that we don't necessarily need to get into, but those intake sessions are longer because we're intaking 2 children at that point, but the actual therapy sessions are 1 hour long. Yes. That's another wonderful question that we didn't answer in our presentation. PC care can be done in clinic. This project is entirely in-home. So everyone that we see for this project, unless they specifically ask for a clinic service, is seen in-home. Anything else? Well, thank you all so much for listening. Oh, wait, I'm sorry. Oh, how many people have I trained so far? I and one other trainer have trained a number that I don't know in my head. 9? More than that? 9, 10, 11, 12, 13, 15.
10?
15,
Deanna says
10, plus external agencies. 15 sounds right. All right, thank you so much.
I'm shocked because nobody's walking out the door. Well, maybe almost nobody's walking out the door. I will be brief. If you're looking at your program, it says Anthony Urquiza, closing comments, remarks, something like that. So I will be brief. This is really about mostly saying thank you, but also, as you know, as Brandy and Lindsay just commented, we're putting a lot of effort into PC care because we think it's really important, and it solves some really important issues that are struggles for some cases with PCIT. This does not mean we're stepping away from PCIT. Think of it more as this is a supplement to what we're doing with PCIT. There's an issue here. I want to do a couple of thank yous and then one last remark, and then you're out the door to the 405 freeway. I just said goodbye to somebody who's heading to the high desert, and that is a painful thing to complicate, just to contemplate, because that's a good 3 hours on the freeway in a car at 20 miles an hour. They're not here, but I want to thank our keynote presenters, Dr. Ford, Ann Easterbrooks, and Isaiah Pickens. I thought they were wonderful, and I was particularly appreciative of the fact that many of you were writing notes when they were talking. That is a very good thing. We had a lot of other presenters who provided information, so I want to say thank you to them. We have a lot of care center people here. Certainly Lindsay, Deanna, I don't know where Deanna is over there. We have a number of research assistants people here that work with us on a daily basis, and we're really pleased to be able to have them, to be able to share this time, to come down with him, to go partying on Wednesday nights, which they do, so that's a good thing. They're all led, bossed around, coordinated by Dr. Timmer, and so thank you, Dr. Timmer, for doing that. And then she passes on her bossiness to Deanna, and Deanna does it. So I just want to say that. Thank you very much for all of your effort. One last comment that I want to make, and I'll send you on your way. Somebody asked me earlier about why we have conferences, and I have said this before. I don't know that I've said this this year, but I've said this before. You are a group of people who speak a lot of the same language. When I talk about a labeled praise that has meaning for you, you know what that means. You've done that. When I talk about giving a first timeout or going through a first PDI timeout sequence thing, you know what that means. And you know that it's really difficult to be in a warm room when you're doing that and you're really anxious. You guys know what that means. It has some value to you. When I talk about being able to share the concerns or the feelings, or to be able to come to a place like this and learn new ideas, that also has some value to. Really what I'm talking about is the language and the traditions, and I'm really talking about culture. And a lot of people in this business, when they get into issues of implementation and really developing, disseminating treatment, they think about lots of sort of theoretical concepts, but in some ways it's really just as simple as you are part of a culture of PCIT therapists who use a lot of the same things that live and reside in you. And that is a really important thing. Because when we talk about fidelity, when we talk about having some sense of what you do today and what you do with your clients next week or a year from now, and it has some sense of integrity and it works, we're really talking about the glue that makes you be committed and be there is associated with this idea of culture. And one of the ways, if I was talking about Latina families, I might be speaking about the celebration and the joining that comes together with the quinceañera. There are lots of times where different cultural groups come together and they celebrate ideas and values, and they come together and they join and they share. And that's what we do with our PCIT conference. That's one of the really important reasons why we have our PCIT conference, so that you can sit next to people and hear important information or new information, but also because you can sit next to people, and if somebody says something to you that's new or you don't understand, then you can say, what do you think about this thing that Isaiah Pickens just said? And if I was watching when Isaiah Pickens was talking and Dr. Blacker was sitting in the back room writing frantically on her notepad, that's what I want. I want when Julian Ford talks about trauma, for it to have some sense of this new disorder that he's talking about, to have some sense that you guys see that with your clients, and it adds to your sense of understanding of what you do, but it also adds to the sense of this culture that you have. And that really, at least from what I've seen so far, is the key to being able to sustain with some degree of fidelity. So I want to thank you for coming here and sharing with your thoughts and your ideas and listening to what we had to say. And most importantly, drive safely going back home. So thank you very much.